So, good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. So, good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. Over battery. So, good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. Over battery. So, good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. Over battery. You need to get me the battery, sir. Where are your batteries? Yeah. So every day evening we have a session ideally from 6 o'clock to 8 o'clock. And in 2 hours, we'll try to revise about 200 points. And if we take ENT, there are 2,500 points, entire ENT. And the entire preventive medicine, it is about 4,000 points. Out of these 4,000 points in preventive medicine, 2,000 points, one round if you listen, you don't need a revision. About 1,500 points require at least second round. And about 400-500 points before exam, you need to revise. So that is a goal. So already we finished the first 75 points in the ENT. So today, from point number 76, we finish about 100 points. So I'm very happy to see Lokesh, my parent doctor, Lokesh from Usmania. You are now ENT after exam going. Very good, very good, very good. So thanks for coming, because to have students in a classroom before your eyes, we had all been craving for the past 2 years after the COVID, right? So before we used to have about hundreds of students sitting in this classroom. So let's make the great beginning. I hope you got the notes. Great. Now, Malleus. Malleus, Incus, Stapes are the three important ossicles. Malleus is like a mallet, right? Which is used by the hammer. And it is placed most laterally between Malleus, Incus, Stapes. Malleus is most lateral. So most lateral means it is more closer to tympanic membrane, right? And it is about 7.5 to 9 mm long. There's a head, there is a neck, there is an anterior process, lateral process, and manubrium and umbo. These are the parts of the malleus, is what you have to emphatically remember. So here you have the head and an articular facet, which will connect one ossicle with the other. And there is one anterior process, a lateral process, a manubrium, and this is the typical structure of the malleus. Coming to incus, incus is like an anvil. So between malleus, incus, and stapes, which is the largest ossicle, is the favorite question of the examiner. It is the incus. And incus is placed medial to the malleus. It has got a body, a short process, long process, and a lenticular process. These are the components of the incus. Out of the three ossicles, the shortest ossicle, shortest bone, is the stapes. Stapes is like a stirrup, right? A stirrup is what you're able to see here, a stirrup. And Basically, stapes is most medial, then comes incus, right? And the malleus, right? Now, stapes has a capitulum, the two crurae, and a footplate. That's what we need to basically remember. Now comes Batti Marne wala item for the entrance exam. What are the dimensions of this footplate of the stapes? You are not going to forget this. 3 millimeters long, 1.4 millimeters wide. I think you all remember 30 millimeters is 3 centimeters, 14 millimeters is 1.4 centimeters. So 1.4 millimeters is the typical dimension. So tomorrow when you become an ENT surgeon, you will be using an operating microscope when you are a plastic surgeon or a ENT surgeon, right? So footplate of the stapes, between stapes, incus, malleus, which is most medial? Stapes. So basically stapes will be abutting the oval window. It will be abutting the oval window. To abut that, it has a ligament, which is called annular ligament, is what you have to basically remember. So oval window, stapes. Stapes, oval window. This is what you need to remember for the tomorrow's exam. Now, how is the embryological development? One of the favorite questions of the examiner. Malleus develops from Meckel's cartilage. M for malleus, M for Meckel cartilage. And you need to remember, first branchial arch derivative is malleus. In the past 24 years, PG medical entrance, this question had been asked at least 15 to 20 times. So you should not forget it. Right, doctor? Then, stapes. Stapes develops from second branchial arch, except the footplate, which typically, along with the annular ligament, which is abutting it to the round window. Is it round window or oval window? Oval window, sorry. Oval window. So, the footplate of the stapes and the annular ligament, they develop from the otic capsule, is what you need to remember. And the remaining part of the stapes all develops from second branchial arch. So how will you remember? Yes for stapes, yes for second branchial arch, yes for stapedius, yes for seventh nerve that innervates the stapedius. This is the typical 4S that you need to remember. When do ossicles ossify? Is the favorite question of the examiner. Can the online students can punch whether the voice is loud and clear for all of you? Yeah. So 4th month of intrauterine life. So how will you remember? Malleus, incus, stapes 3. So remember 4th month is of the intrauterine life. So there are few challenges for entrance preparation, doctor. First, you need to know what to read, what you need not read. Then out of what you read, there are some places where you need to understand logic. For example, diabetes insipidus. It is a diuretic condition because there is no antidiuretic hormone available. But the treatment of choice of diabetes insipidus is thiazide. Thiazide itself is diuretic. So you are using a diuretic to treat a diuretic condition. But there is a logic behind it. Right? Similarly, renal tubular acidosis. You have type 1 and type 2 renal tubular acidosis. Which type of renal tubular acidosis you see nephrocalcinosis? Why not in the other? Logical. जो लॉजिकल होता है बट्टी मारना नहीं. We should not monk. Second, Eustachian tube length is how much? That is no logic. It is only bloody remembering it. So such things require the last moment, last 30, 40 days revision. So totally in 2,500 pages notes, I will be giving you 64,000 points in 19 subjects. Out of that, around 20 to 25,000 points, one time is enough. Another 20, 25,000 points, at least one more round of review. 10,000 points require last 30 days of revision. So totally, if you give me 1,000 hours of your life, 600 hours of your life, first round of revision we will together do of all these 65,000 points. Automatically, you will get AIMS, PGI everywhere. Now, what is the importance of ossicles in the ear? They're the first bone to ossify is what you need to basically remember. First bone to ossify. Now, you have two types of joints in the ossicles. Incudo-malleolar joint, incudo-stapedial joint. These two joints between the incus and stapes, incus and malleus. These two joints are synovial joints, is what you need to remember. Now, one of the favorite MCQ of examiner is, what type of joint is incudo-malleolar joint? Saddle, like you sit on the horse. So you have a convex surface, you have a concave surface, they both are abutting each other. Then incudo-stapedial joint is a ball and socket joint, is what you need to emphatically remember. Now comes the favorite question of the examiner. What are the two muscles in the middle ear? One is tensor tympani, other is stapedius. Tensor tympani develops from first branchial arch, stapedius from the second branchial arch. All of you know very well. First arch nerve is fifth, trigeminal. Second arch nerve is seventh, facial. That's what we need to remember. So if you look at this tensor tympani, doctor, it is innervated by, very good job. You got one student from Usmania. Tomorrow you should get 10 students from Usmania.
Yes, okay.
Very good, very good. So once upon a time we used to have Usmania, Deccan, Shadan. They're all very close by. So this class used to get filled with almost all 70, 80 students. Every day evening, 6 o'clock, they used to come. We used to get the Irani chai and we revised medicine, surgery, gynops and all. One of the batch, one of the student in that batch, Karthik, recently met me. He is a cardiologist. So we were just remembering the days when we used to spend in the evenings. So Usmania Medical College means your cream of the country's merit, right? So the same cream need to emulate the success, and always it is enjoyable. Students are inspiration for a teacher to come back and do a revision. So ENT will be revised by Dr. Chandrasekhar, ENT surgeon, excellent teacher. Surgery will be taught by Dr. Vishal Soni. He's an excellent teacher. Of course, whenever they don't come, I come and teach. I see to that everyday class is on. That's most important. But I am MD in general medicine, basically, from Nizam's Institute of Medical Sciences. So medicine always is like a religion for me, right? So, yeah. Tensor tympani. Tensor tympani comes from Eustachian tube, pharyngotympanic tube, greater wing of sphenoid, and there is its tensor tympani's own bony canal, and it inserts into the upper part of the middle of the malleus, is what you have to basically remember. Now, tensor tympani is by the mandibular division of the trigeminal. So trigeminal has mandibular, maxillary, ophthalmic, 3 divisions. Stapedius is supplied by the branch of the facial nerve. So what is the function of tensor tympani, doctor? Once tensor tympani contracts, it pulls the handle of Malleus. It will pull the handle of Malleus medially. Between Malleus, incus and stapes, which is most lateral? Malleus. So it will pull the handle of the Malleus medially, and that will tense the tympanic membrane to reduce the force of the vibration in response to loud noise. Right? When your girlfriend is shouting in your ear, "Where are you, darling? You're missing in my life when I need you the most." Then it is your tensor tympani which is saving you from becoming deaf. Now, function of Stapedius. Once more, Stapedius also contracts in response to loud noise. It pulls the stapes posteriorly and prevents excessive oscillation. So between Malleus, incus and stapes, stapes is most medial, and it is abutting the old window. So any vibrations of the stapes will cause movement in the perilymph, and that oscillations are reduced by the Stapedius muscle. By pulling the stapes posteriorly is what you have to basically remember. Stapedius originates from a small bony point which is called pyramidal eminence. And which part of the stapes does it insert? Neck of the stapes is the point where Stapedius goes and inserts. Now comes our mastoid bone. What type of bone is mastoid? Mastoid is a cancellous bone. Otherwise, a spongy bone is what you need to basically remember. Now, this mastoid has an antrum. Antrum typically has got all air cells. So, which part of the calvarial bone is this antrum located? It is in the petrous part of the temporal bone, in which the mastoid antrum is an air silence, is what you have to basically remember. Now, if you look at the mastoid antrum, you should know the boundaries, because antrum is the place where any infection gets consolidated in mastoiditis. That's the reason you need to know the boundaries. One of the favorite question of the examiner. Mastoid को एक roof है. The roof is formed by the tegmenantry, and it is separating the temporal lobe of the brain in the middle cranial fossa, and the mastoid antrum are separated by the tegmenantry. Antero-inferiorly, matlab mastoid is here, antrum is here. Antero-inferiorly, you have the facial nerve canal, which is called fallopian canal. Lateral wall is formed with the squamous part of the temporal bone and easily palpable behind the pinna. Then the medial wall of the mastoid antrum is related to the posterior semicircular canal, and the mastoid antrum typically in its upper part of the anterior wall opens into additus, opening of additus. So these are the typical boundaries. Preparation for entrance exam is all imagination. Tomorrow when you become an ENT surgeon, every day you will be operating. But if you become cardiologist, you don't need this. But to become cardiologist, you need this, right? So that's the reason, whether you like it or not, some things you need to relate very well in anatomy, doctor, right? Now, if you look at the digastric muscle has a posterior belly, anterior belly. The digastric muscle's posterior belly forms a groove at the base of the mastoid bone. And this groove is very important because typically this is the point where it is related to the facial nerve, and it acts like a landmark for the facial nerve, because through the stylomastoid foramen, the facial nerve enters into the parotid, temporal, mandibular, zygomatic, buccal, the 5 branches, pes anserinus, it's called. So the facial nerve will be forming. Now, if you look at the mastoid antrum, the antrum is developed very well at birth, but it is not yet pneumatized. The pneumatization of the mastoid antrum begins in the first year, and it takes 4 to 6 years of age by the time when it is complete. So this kind of points, no, doctor, you try to tick mark them so that you keep them in second round revision required, right? Because first time knowing is already knowledge, and revision of it is wisdom, and wisdom is needed for cracking entrance. Don't read so much of content. I will read Harrison, I will read Nelson, I will read this book, that book. You won't become knowledgeable by reading books in medical college. In medical college, the whole idea is get working knowledge, practical knowledge, how to treat TB, how to manage diabetes, how to administer insulin, right? How to manage a DKA, how to do an intubation, how to do a venesection, how to manage fluids, electrolytes, which can kill the patient, how to identify VT, VF. These are day in and day out problems. Nothing related to knowledge. So that's the reason knowledge is different to crack entrance exam, which is like a Bornavita quiz contest. Kaun banega karodpati. And practical skills are different. So to become a strong practical doctor, you need only 10% of knowledge. But to crack entrance exam, unfortunately, you require useless knowledge, almost 80%, right? So that's a point I like to once more re-emphasize to you. Now, if you look at the mastoid antrum, I'm very happy to see 5 online classmates. Very good. In the adult, the mastoid antrum, it is very close to one anatomical landmark called suprameatal triangle, which is also called McEwen's triangle. So it lies 12 to 15 millimeter deep to this suprameatal triangle. At the time of the birth, if you look at the mastoid antrum, it is just 2 mm deep to the suprameatal triangle. And the thickness of the bone increases by the time you reach puberty, almost 1 mm per year. So that is the reason mastoid antrum is very easy to approach in a pediatric population. That's the point. Now comes a very important question. What are the boundaries of this McEwen's triangle? Emphatically, you should remember. So please remember, doctor, above is the temporal line. Above is this temporal line. Antero-inferiorly by the external auditory canals, posterior-superior bony segment. You know, this is external auditory meatus. It has one anterior part, posterior part. Posterior part piche hota hai. So posterior-superior segment of the bony part of the external auditory canal, and posteriorly by a line which is drawn as a tangent. If you line a tangent to the external auditory canal, that forms the posterior boundary of the McEwen's triangle. A point number 100 को भी आप mark करके रखो, कल के exam में जरूर पूछेगा. Now comes the Eustachian tube. So what is Eustachian tube is doing? It is connecting the nasopharynx with the middle ear. So it is connecting the tympanic cavity with the nasopharynx. It is also called pharyngotympanic tube, is the other name which is being given. Now comes the favorite MCQ. What is the epithelial lining of the Eustachian tube? Ciliated columnar epithelium is a type of epithelium, is what you need to remember. And what is the purpose of Eustachian tube? It typically equalizes the pressure between both the sides of tympanic membrane, right? So Typically, you have the tympanic membrane here. So typically, it is a pharyngotympanic tube. So both the sides of the tympanic membrane, it typically causes equalization of the pressure. The length of the tympanic, Eustachian tube, 36 mm, which is 3.6 centimeters. Lateral third is bony, medial 2/3 is fibrocartilaginous, is what you have to basically remember. Right, doctor? Similarly, external canal also. You should know which part is bony, which part is cartilaginous. Sinus, what is it? Fissures of Santorini, all those things we discussed in the first 75 points, right? So don't worry, this the other first 75 points video is there in the YouTube. Now in adults, what is the angle at which this Eustachian tube? It is 45 degrees with the sagittal plane. But if you look at the infants, their Eustachian tube versus the adult Eustachian tube, what are the differences? Eustachian tube in the infant is short. Length is only 13 to 18 millimeters. Please don't forget. It is more wider. It is placed more horizontally. So that is the reason any infections, any oral infection, mouth, can pass through pharyngotympanic tube into the ear. That's the reason the middle ear infections are more common in the case of the infants, is what you have to emphatically remember. Now, if you look at the Eustachian tube, there are two muscles that you need to remember. So ultimately, what is the goal? The Eustachian tube need to be maintained patent. It is like a rubber tube, cartilaginous. For that, you have tensor veli pallati, levator veli pallati. So tensor pallati, what does it do? It is basically both these muscles are wrapping around the, you can see, this is tensor veli pallati fibers around the Eustachian tube. This is the levator veli pallati muscle. So ultimately, what they are doing, they are trying to keep it patent, Eustachian tube patent. So one of the favorite MCQ of examiner is, what is the nerve supply? Tensor pallati is supplied by the mandibular division of the trigeminal. Levator pallati is supplied by the pharyngeal plexus, which is derived from glossopharyngeal nerve. That's what you need to basically remember. Now, what is the blood supply of Eustachian tube? Ascending pharyngeal artery, middle meningeal artery, artery to the pterygoid canal. Artery to the pterygoid canal is a branch of the maxillary artery. So basically, you should know external carotid artery, internal carotid artery. Two. How many branches of internal carotid artery are there in the neck? Internal carotid artery has how many branches in the neck? Zero. That's a favorite question, right? Internal carotid artery doesn't give any branches in the neck. Internal carotid artery only gives branches after it enters calvarium. So your middle cerebral artery, anterocerebral artery, they both are from carotid system. Whereas the two vertebral arteries combine to form basilar artery, divides into postal cerebral artery, and that connects with the middle cerebral artery to the posterior communicating artery. That's how circle of Willis is there, no doctor. So no worries. So maxillary artery is a branch of the external carotid system. So maxillary artery branch is the artery of pterygoid canal that supplies the Eustachian tube, is what you have to emphatically remember for the tomorrow's exam. Now, what is the venous drainage of the Eustachian tube? You can see here, this is called pterygoid venous plexus. So all the Eustachian tube drains into pterygoid venous plexus, is what you need to basically remember. Now, what is the nerve supply of the Eustachian tube? It is the tympanic plexus. So, tympanic plexus is formed by various nerves. Tympanic nerve, which is the glossopharyngeal nerves branch, is the one which basically you need to remember. Right now, middle ear story is more or less done. Now comes inner ear. Inner ear has a bony labyrinth within the petrous part of the temporal bone, right? Along with the membranous labyrinth. Now we need to remember, you have an external auditory meatus. Obviously, there should be some internal acoustic meatus, right? All acoustic neuromas typically are very close to that, and they cause the compression of the facial nerve and all the nerves. Now the question comes, which bone is this internal acoustic meatus located? So we should remember that it is the petrous part of the temporal bone where you have the internal acoustic meatus. And internal acoustic meatus is the opening through which your inner ear is connected to the posterior cranial fossa. That's what you need to basically remember. So some of you tomorrow will become top neurosurgeons, left and right, day in and day out, operating on acoustic neuromas, right? Now, if you look at the bony labyrinth in the inner ear, what are the components of the bony labyrinth? What do you have inside the bony labyrinth? You have a vestibule, semicircular canals. There is a cochlea which is filled with a perilymph. Perilymph resembles CSF. It is rich in sodium, poor in potassium. So these are the three components of the bony labyrinth: vestibule, semicircular canals, and the cochlea is what you need to basically remember. Now, this vestibule typically has five openings into which the semicircular canals open, right? 5 openings into which the semicircular canals open. So there are 3 semicircular canals, and each semicircular canal is supposed to have 2 openings. So 2, 3, 6 it should be, but it is not 6, it is only 5. That is what examiner is going to catch your tail, right? In exam hall, that is the reason there is no guesswork. You are guessing in exam hall means you are definitely doing it wrong. All guess should happen here. Now, if you look at the vestibule, it has a saccule, utricle, which is a spherical recess called utricle. Elliptical recess for utricle, spherical recess for saccule, and the opening of the aqueduct of vestibule, which is called endolymphatic duct. So that is the structure of vestibule. So vestibule should receive things from utricle and saccule, and it need to let out through the endolymphatic duct. So all these things are located along the medial surface. If you cut that egg called vestibule, in the medial wall, you will see saccule, utricle, and the endolymphatic duct is what you need to basically remember. Now, in the lateral wall of the vestibule, you have the oval window, right? Oval window. Because inner ear is more medial. We are talking about this vestibule, which is there inside the bony labyrinth of the inner ear. So obviously lateral to that you have the oval window, and lateral to the oval window, you have the middle ear structures, right? So that's how you need to relate. See, it's a box. So in this box, what do you have? We are talking about the vestibule here, and the middle ear here, middle ear. Today I forgot my connection to pen. Then you have the oval window here, and middle ear is connected to this vestibule, is what you need to remember. All right. And along the medial wall, you have the, suppose if this is the vestibule, then along the medial wall of the vestibule, you have these three structures. That is saccule, utricle, and endolymphatic duct. These three are the structures along the medial wall of the vestibule. So there are three semicircular canals, the lateral, posterior, superior. They are 90 degrees to each other, is what you need to appreciate. Now, if you look at the bony labyrinth, between the anterior, posterior, lateral, semicircular canals, whatever that area of the bony canal is there, it is called solid angle. It's called solid angle. Now, if you look at the semicircular canal, one end of it is dilated, and the dilated end of the semicircular canal is called ampulla. And what is there? Ampulla ke andar kya hai? There is a vestibular sensory epithelium, and it opens independently in the vestibule. That's what you need to remember. So we call vestibulo-cochlear. Vestibule is related to what? Balance. Cochlea is associated with hearing, right? Vestibulo-cochlear. So we have an ampulla at one end of the semicircular canal, which is having the vestibular sensory epithelium, is what you need to remember. So ideally, the three semicircular canals should have 6 openings. But the posterior semicircular canal, superior semicircular canal, together they form what is called as crus commune, and one opening only. That is the reason totally there are only 5 openings instead of 6 openings. That's what you need to ultimately remember. Now coming to cochlea. Favorite MCQ, once more batti marne wala item. 2.5 turns. The cochlea takes 2.5, not 1.5, 3.5, 4.5. And don't sit in exam hall and put a pen in your ear and keep thinking, is it 2.5, 1.5? I think it is 1.5. My friend in the canteen said 1.5. You will answer, come out of exam hall and say, oh, I did it wrong. So, feeling tense about exam, all these are artificial feelings, bakwas. See, doctor, marriage is a beautiful experience. If you want to marry, you have to be happy. But before marry, if you feel I'm feeling tense to get married, my bachelorhood is ending. Yeah, your bachelorhood will end. There is no other option. So also, notification आ गया, मुझे tension है, नहीं तो एग्जाम का डेट another 48 hours में मुझे tension है. Tension का जरूरत नहीं है. So there are 65,000 points, 2,500 pages notes I will give you. Out of that, actually, you yourself can read 30,000 points. But to read points, you require some imageological background. So virtually, I will give you 65,000 points with 65,000 images, right? So what happens is it becomes easier. So your job is just tick the points that you feel you are not going to remember and you need to remember last time. And those which you feel, I don't need this next time. I know this. I know Bony Labyrinth, Membranous Labyrinth. This point I don't need. And those you need to repeatedly repeat, right? Like Eustachian Tube length. Whenever you go to canteen here and there, you keep repeating. That's a plan. So if you look at the coils of the bony cochlea, they typically turn around one central bone, which is called, there is one central bone This is the central bone around which this coiling occurs, this 2.5 turns coil. And that central bone is called modulus, is what you need to remember. So what is the length of the cochlear tube, which is totally wound into 2.5 times? It is 30 millimeters is the length, is what you need to remember. I'm so happy to see Dr. Nikhilesh Yadav, who is online, and many more. Very good, doctor. So, cochlea. All right. What is the function of cochlea? Vestibule is everything about balance, because the ampullary vestibular neuroepithelium. Cochlea is everything about listening. So how does it achieve that? Cochlea converts the mechanical sound waves into electrical signals transmitted to brain. And mainly it is the hair cells which are there in the cochlea which are basically responsible. Now, if you look at this modulus, that bony part, typically it has a spiral ganglion, and they innervate the cochlear hair cells. And there is an area which is called Rosenthal Canal. You are able to see here, doctor? Rosenthal Canal. So Rosenthal Canal is the place where the spiral ganglion cells are destined to go and innervate the cochlear hair cells, is what you need to basically remember. And there is a place called spiral lamina. So this is basically called spiral lamina. So there is a thin shelf of the bone within the lumen of the cochlea, which is called the bony spiral lamina, is what you are able to identify here. Now, what is the purpose of this spiral lamina? The spiral lamina divides the cochlear canal into a upper scala vestibuli and a lower scala tympani, is what you need to remember. So you have an upper scala vestibuli and a lower scala tympani, is what you need to remember, because of this osseous spiral lamina, is what you need to remember. Now, the scala vestibuli, upper part, scala tympani, they are continuous with each other at the apex of the cochlea through an area called helicotrema, is what you have to understand. Then scala vestibuli is closed by the footplate of stapes, right? Then the scala tympani, the lower part, is closed by secondary tympanic membrane. That is the round window. The one which is there along the round window, that is secondary tympanic membrane. So now I think you got the idea. What is cochlea? What is helicotrema? Right? What is modulus? Where is scala vestibuli, scala tympani? How is stapes aligned? Where is the round window? Where is the oval window? Clear? Where is the perilymph? This is very, very important illustration, doctor. So that is the reason once upon a time you require to go through the atlas in the library. Today, Google, you have all images, all videos. There is nothing left to imagination. All knowledge is there on the YouTube, right? Now, aqueduct of cochlea. What is the importance of cochlear aqueduct? So here you have the cochlear aqueduct. This is the one which connects the scala tympani with the subarachnoid space, is what you need to basically remember. Now, if you look at the spiral lamina, osseous spiral lamina, it gives an attachment to which this basilar membrane is anchored. which is very important. It is like the tabla membrane on which you play the tabla, right? Now, if you look at the bony labyrinth, there are 3 openings in the bony labyrinth. Now, I think by now you understood. There is one oval window present in the scala vestibuli and closed by the footplate of stapes. There is a round window which is called fenestra cochleae, present in the scala tympani and covered by secondary tympanic membrane. Then, so these are the 2 important openings that you need to remember. Now, what is the venous drainage which is associated? The cochlear canaliculus, cochlea's canal of cochlea, transmits a small vein that goes and connects with the inferior petrosal sinus. So that's how the inner ear, the venous sinuses of the around the brain, all of them are very well related to each other. Now, if you look at the bony labyrinth, how is it connected to the subarachnoid space? Just now we discussed cochlear aqueduct. So that is the reason any infection of this labyrinth can transmit through the cochlear aqueduct and enter into the CSF, Garbhagudi, and lead to development of meningitis. So even inner ear infection also can go to the meninges. That's what we need to basically remember. Now, if you look at the membranous labyrinth is there within the bony labyrinth. And that membranous labyrinth is basically occupied by endolymph, is what you need to remember. So this is how you have the stapes, the oval window or round window? Stapes? Oval window. Then here you have the round window, secondary tympanic membrane, and here you have the perilymph in the bony canal. Then in the membranous part, what you have is a endolymph, is what you need to remember. So the membranous labyrinth is separated from the bony labyrinth by this perilymphatic fluid, is what you have to basically appreciate. So what does membranous labyrinth contain? Membranous labyrinth has a cochlear duct, utricle, saccule, semicircular ducts, endolymphatic duct, endolymphatic sac. These are all the components of that membranous labyrinth into which they're all opening into, right? So this is how you should appreciate now that utricle, saccule, cochlear duct, endolymphatic duct, semicircular ducts, they're all opening into the membranous labyrinth, is what you need to remember. So there are 3 semicircular ducts corresponding to the 3 bony canals. Then where do all semicircular ducts open? Semicircular ducts open into utricle. So there's one utricle, there's one saccule. So utricle is important because all the semicircular ducts, where do they open into? All semicircular ducts open into utricle, is what you have to basically remember. If you look at the ampulated end of each semicircular duct, what we said, there is a neuroepithelium, which is important for your vestibular function of equilibrium. So this neuroepithelium is called crista ampullaris. Crista ampullaris. And what is it important for? So you are going into the reading room, there is a beautiful girl in the reading room, suddenly you turn. That is what? Crista ampullaris is taking care. She is walking very fast. You can't miss the look. You are running behind her. That is linear acceleration. So angular acceleration, you turn towards her. Then your crista ampullaris is the one which basically will sense it. The sensory epithelium, which is there in the utricle. So where do you have sensory epithelium for angular acceleration? Ampullary end of the semicircular canal. Then you have the utricle. Inside the utricle also you have a sensory epithelium which is called macula. Macula is important for linear acceleration and deceleration. You are driving the car. Linear acceleration and deceleration is macula. Angular acceleration is crista ampullaris. Crista ampullaris is there along the ampullary end of the semicircular canal, whereas the macula is there along the sensory epithelium of the utricle. That's what you have to emphatically remember. So now, where is the utricle in this bony vestibule? It is along the posterior part of the bony vestibule. That's a point you need to appreciate. Then what is utricle doing? Utricle is a part of the bony labyrinth. So utricle is receiving all these 5 openings of these 3 semicircular canals. That's what utricle is doing. So that is the reason the semicircular canals will be giving information by their movement to the utricle that this is the linear acceleration, deceleration happening. That's what we need to emphatically remember. So utricle is connected to the saccule through utrico-saccular duct. You are able to see the utrico-saccular duct, and the saccule also lies in the bony vestibule. That's what you need to basically remember. All right, doctor, now I think you understood where is the saccule, where is the maculae, right? And where is the utricle? What is utriculo-saccular duct? I hope you got a complete idea. And along the dilated ampullary ends, what you have is crista ampullaris. That's what you need to understand. Now, how is endolymphatic duct, which is ultimately draining into CSF, is formed? It is the saccular duct, utricular duct. The utriculo-saccular duct is the one which is draining into the endolymphatic duct, is what you need to remember. And the terminal part of the endolymphatic duct is dilated just before it is entering into the CSF. And that is basically called endolymphatic sac. And it is very closely related to the dura, which is part of the petrous part of the temporal bone, is what you need to remember. So now you got an overall idea where is utricle, macule, saccule, all ules, but they are a little bit confusing if you are not very sure 3-dimensionally. Now what is endolymphatic sac? Absorption of the endolymph, which is filling the membranous labyrinth, not perilymph, endolymph. That is the whole purpose of the endolymphatic sac, is what you should remember. Now, there is something called Donaldson's line, which we need to basically remember. So this is a very important surgical landmark for the endolymphatic sac. Tomorrow, what is Meniere's disease? You have 3 symptoms. So DVT, deafness, vertigo, tinnitus. DVT is Meniere's. Meniere's is endolymphatic sac dilatation will lead to Meniere's. And whenever endolymphatic sac is blocked, endolymph cannot pass into CSF. So that will lead to traffic jam. That lead to endolymph to get stagnated inside the membranous labyrinth. That in turn will unnecessarily stimulate all the sensitive structures around it, and that lead to cochlear dysfunction, deafness, vestibular dysfunction in the form of vertigo and tinnitus. That's what we need to remember. So what is the importance of this Donald's line? It typically passes through a horizontal which is bisecting the posterior semicircular canal. So it is bisecting the posterior semicircular canal. That's the reason you need to remember the Donaldson's line, which is a surgical landmark where you are operating on the endolymphatic sac, is what you should precisely remember. So the endolymphatic sac basically appears like a thickening of the posterior cranial fossa dura, which is situated inferior to this Donaldson's line. So there's a reason tomorrow when you need to operate on the endolymphatic sac, which is dilated, by doing a fenestration surgery to create the drainage into the CSF, you need to operate inferior to this Donaldson's line, which is bisecting the posterior semicircular canal. That's what you need to basically remember. Now, if you look at the cochlear duct, it is also called membranous cochlea, or the scala media is the other name given for the membranous cochlea, right? So you have scala vestibuli, scala tympani, and you have the scala media, which is nothing but the cochlear duct or membranous cochlea is what you have to ultimately remember. So cochlear duct is a blind coiled tube, and it takes how many tons? 2.5 tons to 3/4 tons around a bony part which is called modulus is what you have to ultimately remember. Now, if you look at the cochlear duct, that is, I am talking about the scala media. If you cut it, it is triangular. It is triangular in cross section. So, what are the components of this triangular cross section? You have a basilar membrane, and basilar membrane is originating from that. Just before now, there is a bony septum from which this basilar membrane is coming, right? And basilar membrane supports the organ of Corti. Then you have a Reisner's membrane which separate the scala media from scala vestibuli. Then you have a stria vascularis, which has got the vascular epithelium, which is secreting the endolymph. That's what you need to remember. So perilymph is similar to CSF. Endolymph is produced by stria vascularis, but endolymph drains into CSF. Huh? Endolymph? Endolymphatic sac. Endolymphatic sac ultimately drains into CSF. Right? No. It is to the dura mater, ultimately it has to drain, no? Yeah. So, cochlear duct is connected to the saccule. Cochlear duct is connected to the saccule by the ductus reunions is what you need to basically remember. Now, if you look at the cochlea, now comes the favorite entrance point of the examiner. You have a basal part of it in this area, basal part of it, and you have an apical part of it. The basal cochlea responds to higher frequency, apical part responds to lower frequency. Accordingly, deafness also, high frequency, low frequency, two types of deafness. We will come to those points also. Now, perilymph, it resembles ECF. It is rich in sodium ions, is what you need to basically remember. And what is perilymph filling? It is filling the bony and the membranous labyrinth, fills the space between bony and membranous labyrinth. Perilymph communicates with the CSF to the aqueduct of cochlea, which opens into the scala tympani near the round window, right? So you have the round window here, right? Then endolymph fills the entire membranous labyrinth. Endolymph resembles intracellular fluid, rich in potassium, poor in sodium. That's what we need to remember. And from there is endolymph produced. Endolymph is produced by the secretory cells of the stria vascularis of the cochlea and by the dark cells. Where are the dark cells present, doctor? Something should be very dark. It is utricle, right? It is the utricle. Is what you need to, and near the ampullated end of the semicircular ducts and the utricle, you have the dark cells. They also contribute for the formation of the endolymph, is what you need to basically remember. Now, if you look at the blood supply of the labyrinth, Labyrinth is supplied by Labyrinthine Artery. Labyrinthine Artery is a branch of Antro-inferior artery. Antro-inferior artery is a branch of the two vertebral arteries combined to form basilar artery, become posterior arteries. So the basilar artery gives rise to antro-inferior cerebellar artery. And what is the other artery? Posterior-inferior cerebellar artery, pica. And whenever there is any occlusion of the pica, what is that syndrome called? What is the brainstem syndrome that affects the medial, lateral part of the medulla? Lateral medullary syndrome of Wellenberg is because of the pica occlusion. We will discuss that in neurology, no worries, right? So that is the whole idea, doctor. Now, what is the venous drainage of the labyrinth? There are three veins: internal auditory vein of cochlear duct, vein of the vestibular aqueduct. They all ultimately drain into, you need to remember, inferior petrosal sinus and lateral venous sinus. That's how the spread of infection can occur. That's the reason. Now, if you look at the blood supply of middle ear versus blood supply of inner ear, they both are independent. And there is no cross circulation between the two, luckily. Now, if you look at the blood supply of the cochlea and vestibular labyrinth, in the inner ear, you have two components, cochlea and vestibule. They both are segmental. Therefore, cochlea's dining hall is cochlea, vestibular is vestibular. Luckily, what is the miracle of production of God? You won't become deaf and also become vertiginous same time. So God has made in such a way that cochlear blood supply ischemia can occur independent from vestibular ischemia. That's what you need to basically remember. So you can get either cochlear or the vestibular symptoms is what you need to remember. Now, doctor, internal acoustic meanders. One dirty question examiner want to ask you. What is its length? 1 centimeter long, 2 to 8 millimeter vertical length. And this is very important because tomorrow, how do you diagnose acoustic neuroma? So you will be taking a MRI and seeing whether both the sides internal acoustic meanders is of the any asymmetry is there. Based on that, you will basically identify. And where is internal acoustic meanders? Petrous part of the temporal bone, as what we discussed. Now there is something called Bill's bar. Bill's bar is a vertical crest of the bone, and that divides the internal acoustic meanders into a superior compartment and a inferior compartment. Right? So, it divides the superior compartment of the internal acoustic meanders into an anterior compartment and posterior compartment. In anterior compartment, you have facial nerve, and posterior compartment, you have superior vestibular nerve, and these relations are important. Tomorrow, when acoustic neuroma is expanding, first, how will it attack? Which nerve is affected the most? For that, you need to know about the Bill's bar. And the Bill's bar is in turn divided into superior and inferior compartments by a falciform crest, is what you need to understand. Now, what are the structures that pass through internal acoustic meanders? There is superior vestibular nerve, inferior vestibular nerve, facial nerve, cochlear nerve. That's what you need to understand. Now, doctor, the sensory organ of balance. Just before we discuss now, the ampullary dilated end of the semicircular canal has crista, right? So this crista is the most important thing that senses the rotational and angular movement. Whereas macule, which is present in utricle and saccule, it is responsible for linear acceleration, the head tilt, gravity, and all that is basically the macule is what you need to remember. Now, if you look at the embryology, one of the favorite questions, let's come back once more to the gross things in embryo. In the 6th week of embryonic life, there are 6 tubercles called hillocks of his. They appear from first and second branchial arches. So we are having ears means thank God to the first and second branchial arch. And progressively these 6 tubercles coalesce, typically forming our pinna, the auricle. So tomorrow we'll continue discussion. So we finished, what is the time now? In 1 hour, we are able to finish 70 is our run rate. But ideally, I prefer 1 hour, 100. 2 hours, 200 points every day. And your 2,500 points are over in 12 days. And Lokesh should come and tell, I got a distinction score in... otherwise also he would have got, but he is giving us opportunity to study along with him. Right? So, when is the practical exam, doctor? From? June, eh? Oh, and theory exam? 20? 18th to 20th May. Okay. So, 18th means today is what? Oh, we have got how many days? Almost 28 days. Oh, 28 days may I'll finish SPM 4,500 points and ENT will also be done, right? And if I get time, I'll try to also cover up ophthalmology. We have one very good teacher, Dr. Mehboob sir. He is from All India Institute of Medical Sciences. He teaches online. So I will check whether online is better or offline we can manage. Offline is more interesting, right? Once more, we will get another opportunity to study along with you retinoblastomas, retinitis pigmentosas, and complications of extracapsular, intracapsular extraction of the lens, everything, right? So thank you very much for attending. Tomorrow, sharp 6 o'clock, we'll have the class. 6 to 8 we'll have, and also we'll conduct a quiz. 20 MCQ quiz in the middle of 1 hour, 1 hour. That's the plan. Thank you.